talking in terms of preventative oncology and are all breast lumps actually malignancy? Before talking about breast lumps, it is very important to know, like the uterus, the breast is a very dynamic organ. And it also undergoes involuntary processes. It undergoes changes during the early reproductive years, late reproductive years, and especially during the involuntary period. It has many conditions which are not actually disease, but they are aberrations of normal development and do not usually require any intervention. Now, breast screening, as was already discussed, but I would like to point out that it is actually a non-existing reality in India. Only less than 1% women actually undergo clinical breast examination in the clinical setup, and less than 1.3% women undergo screening by mammography in India. There is a late tendency to present late in the Indian scenario, with 50 to 70% of the patients presenting late to our OPDs in the later stages with locally advanced cancers. Now, this context matters. Why? Because in India, the average age of presentation for women with breast cancer is actually lesser than the developed portions of the world. Our average age is between 30 and 50, while in the Western population it is between 50 and 60. So it is very important to enforce screening programs, especially when the patients come to our OPDs. Henceforth, in 2017, the National Program for Cancer, Diabetes and Stroke Prevention did include breast cancer, but they did not go for a routine screening. They advise an opportunistic screening between the ages of 40 and 70. The Breast Imaging Society of India also recommends routine screening between 40 and 70, yearly or biennially, and high-risk screening or early screening between the starting at the age of 25 to 30 for those patients with family history of breast cancer with BRCA mutations, and patients which have a more than 20% lifetime risk for cancers by the various models which was discussed by Dr. Goenka. Now, what are the common breast lumps that present in the OPD in the peri and post-menopausal age? I'll just talk about the common lumps. Those are the fibroepithelial lumps, the aberrations of normal involutions, and malignancies. Now, the fibroepithelial lesions, fibroadenoma, new onset in this age is extremely rare, extremely rare. If a patient is presenting with something like a fibroadenoma, think phyllodes tumor. Aberrations of normal involution do include fibrocystic disease, cysts in both the breast, fibroadenosis, sclerosing adenosis. These are all deviations from the normal development instead of a disease. So they do require some intervention in some cases, but not in all. Now, assessment of any breast lump is triple assessment. Clinical breast examination first. Second would be a radiological investigation in the form of ultrasound, mammography, or an MRI. When do we do an ultrasound? For patients less than 40 years, because they have a denser breast and would obscure smaller lesions on a mammography. Mammography recommended for patients above 40 years of age, because they are undergoing an involution process. They have a more fatty breast, and smaller lesions are more likely to be picked up in these patients. MRI is obviously for special cases. The third arm of the triple assessment is pathology in the form of a fine needle aspiration cytology or a biopsy. But for this age, I personally recommend and reinforce biopsy should be done for cases of breast lump more than 40 years. Now, the first clinical scenario that I would like to discuss is sometimes a patient presents to the OPD. Is it actually a lump? Or is it nodularity, lumpiness of the breast, which we commonly see in these patients in perimenopausal and postmenopausal age group? Is it actually a lump? That is the question. 8 out of 10 patients in the OPD would not be having malignancy and would be having some form of aberration or disorder of normal involuntary process in form of fibroadenosis, fibrocystic disease. Now, what has to be done in these patients? First, obviously, is clinical examination. Second step would be for these patients, do get a screening mammography or an ultrasound for these patients, because obviously it is an opportunistic screening. When they present to the OPD, we do refer them for a screening mammography, even though we know that these patients will likely not have anything on the imaging. Now, when do we intervene for such patients? Patients with lumpiness or nodularity of the breast, and they're very scared that will I develop a malignancy in this case? Will this convert to malignancy in future? there is no evidence of conversion of these lesions to malignancy in the future. And intervention is only required when the patient has associated clinically significant mastalgia, which is defined as a pain score of more than 3 on visual analog scale, and the mastalgia is lasting for more than 7 days in their monthly cycle, and it is incapacitating and affecting their daily life. So intervention has to be given in these patients. Another indication for intervention in such patients, when we find an underlying, there is an incidentally detected underlying lesion which looks suspicious. So these patients need to undergo some form of intervention. Now the patients who have clinically significant mastalgia, fibrocystic disease, which is uncomfortable for these patients. Another indication. And it has shown very good response for patients with mastalgia and fibrocystic disease, with up to 87% response, along with the conservative measures that we use. Now, ormeloxifene does have a side effect of increasing the ovarian cysts in patients with pre-existing ovarian cysts, so has to be deferred in such patients. It looks like a fibroadenoma, it feels like a fibroadenoma, but is it actually a fibroadenoma? There are very high chance that it is not a fibroadenoma and it is a phylloid tumor. On clinical examination and on FNAC, both of these lesions would actually appear the same. Clinical examination, both these lesions will have smooth, well-defined margins, some bossylated surface, and mobile within the breast. FNAC, because most of us would go for an FNAC first. FNAC in both cases would reveal a fibroepithelial lesion. Pathologists in this age group would not give you a clear-cut fibroadenoma diagnosis. So what do? We go for a upfront biopsy for these patients. And why is a biopsy required? Because it helps us distinguish between a fibroadenoma and a phylloid tumor. Now, why phylloid tumor is so important? See, fibroadenomas are benign lesions. They have no tendency to conversion to malignancy, but phylloid tumor in itself are defined in 3 categories: benign, borderline, and malignant. So these tumors have a tendency to turn aggressive, be malignant, and hence these tumors need to be addressed. And this is also a common malignancy of the perimenopausal and the postmenopausal age group. So always a biopsy, and it has to be divided into 3 groups. It is very important to note that it has a very high recurrence rate. Despite surgery, despite intervention, overall recurrence rate, even after excision of a phylloid tumor, is 21%. And it is between 23 to 30% in cases of malignant phylloid tumor. Management is always and always surgery for these patients, because radiotherapy and chemotherapy have very limited role. They have no prospective randomized controlled trial, and they have shown to be very limited data for these kind of modalities, and very, very little response, only to be used for recurrent, malignant, and unresectable cases. Now we all know when should we be worried about a case of breast lump? What are the warning signs that are present when a patient comes to the OPD and has a breast lump? The lump is hard or firm in texture, it is irregular and asymmetrical in shape, and it is fixed to the breast tissue, and it is not mobile. The overlying skin shows purely orange appearance, there is puckering or dimpling of the skin, and there is diffuse erythema. Other signs may be nipple inversion or retraction. There may be nipple discharge in such cases. And sometimes when the patient presents with a Paget's disease, there will be scaling and eczematous changes of the nipple. There may be involvement of the axillary nodes as well. And radiologically, these lesions will appear irregular on mammography with spiculated margins. There may be associated microcalcification when DCIS is present. And when we send these patients to a radiologist, they'll give us a category, a BI-RADS category of the risk of, this actually tells us about the risk of malignancy and the action that is required. So up to BI-RADS 3, because the risk of malignancy is less than 2%, usually they do not recommend that we go for a pathological diagnosis. But beyond BI-RADS 3, because the risk of malignancy starts increasing rapidly, we do go for a tissue biopsy instead of an FNAC. Now I'll tell you why a tissue biopsy is so important. Now, you have done a biopsy. First, let us compare two situations. One situation is we did an FNSC and it is a ductal carcinoma, and the second situation is we did a biopsy and it is a ductal carcinoma. Now, FNSC does not give us the basement membrane. It does not tell us about the invasive component of that carcinoma. It does not tell us whether it is an in situ carcinoma, whether it is an invasive carcinoma. And thirdly, the most important thing, it will not help us in getting the immunohistochemistry, that is the estrogen progesterone receptors and the HER2/neu receptors. Why are these receptors so important in breast cancer? Because now they are included in the staging itself. They are included in the TNM staging. The presence of these receptors up stages or down stages breast cancer. So always and always and always, please get these receptor studies. I see many patients coming in with an FNAC, want to undergo surgery, but that is not the case. Receptors decide us in staging the patient. They help in decision making regarding the treatment, whether these patients should undergo chemotherapy prior to surgery, whether they should receive immunotherapy or targeted therapy. They are very important in decision making and obviously for prognostication. Now, the spectrum of aggression of these receptors is commonly divided into 4 types. Estrogen and progesterone positive tumors with other negative markers. These can be divided into 2 types. The more aggressive type is the luminal B with higher proliferation index, that is Ki67. And luminal A, which is ERPR positive and low proliferation index, that is less than 14 to 20%. Now, luminal A has a better prognosis and a very good 5-year survival rate, and these patients may benefit from only hormonal therapy, and they can completely miss the chemotherapy part. Luminal B patients do benefit from chemotherapy. The other 2 types, that is HER2/neu enriched type and triple negative, that is ERPR negative and HER2 negative types, they are aggressive forms of cancer and do require some form of systemic therapy. Now, what is the clinical utility? It is always, these markers help us in navigating the gray zone. They help in decision making. As I told you, luminal A patients, ERPR positive, low Ki67, they can completely go for a chemo sparing regimen, only hormonal therapy. They do have to undergo some form of genomic assays like Oncotype DX or CanAssist to refine their risk of recurrence and give a percentage of what would be the benefit of receiving chemotherapy in these patients. And now this, I don't think the medical oncologist sitting here would be very happy with this flowchart, but this is a very oversimplification of the treatment protocols that we follow. Now, for patients with hormone-positive tumors, we've done a biopsy, we have done the radiological imaging. Now what? We have to plan the treatment. Now, hormone-positive patients, if they are operable and node negative, go for upfront surgery and systemic therapy later. That is the overall consensus of all the guidelines that we follow. Patients with HER2 positive cancers, whether they be ERPR positive or ERPR negative, we have to decide whether these patients should undergo chemotherapy first or whether these patients should go surgery first. These patients, if they are operable less than 2 centimeters, node negative, can go for upfront surgery, but they do require adjuvant chemotherapy and targeted therapy followed, may or may not require radiation. Patients who are triple negative, for them the cutoff is even less than 1 centimeter, should be they should go for directly go for surgery if they are node negative and there are no aggressive factors. So to summarize, hormone positive, operable, go for surgery first. Hormone negative, HER2 positive or triple negative cancers, they should be assessed on the basis of their operability, size and nodal status. If they are in the favorable criteria, go for surgery first, followed by systemic therapy. Otherwise, even for operable cancers, but node positive or more than 2 centimeters, please send these patients for systemic therapy first, because beyond this size, these diseases become a systemic disease and they are no longer a localized disease. What we do see in a gynec OPD is patient would come to you because they are taking these hormone positive patients would come to you because they are taking SERMs, selective estrogen receptor modulators. Postmenopausal women are usually put on aromatase inhibitors with bisphosphonates. Aromatase inhibitors are combined with bisphosphonates because they do tend to weaken the bones. And because tamoxifen is given in the premenopausal age, tamoxifen has a protective effect on bone. Aromatase inhibitors causes osteoporosis, it weakens the bone, has to be combined with bisphosphonates. Patients coming to you with on tamoxifen, be aware these patients are at a risk of endometrial hyperplasia and endometrial malignancies. Now, to simplify the surgical management of these patients, is mastectomy the only option? Now, breast conservation, it has been shown across various studies, is non-inferior to mastectomy in patients of breast cancer. Although breast conservation requires mandatory adjuvant radiation, patients undergoing mastectomy also will require radiation in certain cases. So we cannot always say that patient undergoing mastectomy will not require radiation and patients undergoing conservation will require radiation. No, that is not the case. Breast conservation does mandate radiation, but not all patients who undergo mastectomy will be saved from radiation. In terms of the recurrence rate and overall survival, breast cancer and breast conservation surgery and mastectomy, both of them are non-inferior. So there is no major difference between the risk of recurrence and overall survival. So I would suggest that please tell these patients to think about their options regarding conservation versus mastectomy. We have now started de-escalating the axillary dissection because in node-negative patients, it is seen that addressing the axilla does not add to the overall survival, and de-escalation helps prevent the morbid lymphedema that these patients would actually land up in. And now conservation is being paired with oncoplastic reconstruction, and it gives better patient satisfaction and quality of life. Sometimes there are histopathological surprises on biopsy.
Sorry, Dr. Garg, our timer is disturbed, so please wind up.
That's my last slide. Now, there are some histopathological surprises. They are not cancers, but atypical lesions. Some of these would require only observation, and some of them would require surgery.